Katrese King is a registered nurse with 25 years of experience in women's health. She currently serves as nursing team lead and outpatient family support nurse. She has an extensive training in perinatal bereavement and perinatal mental health. Katrese's passion is to advocate for all women, especially for women of color, in spaces where they do not feel represented. Please help me in joining Katrese and as our next presenter about high-risk pregnancy and loss in the Black, Indigenous, people of color community.
Good afternoon. Good afternoon. Thank you so much for having me. My name is Katrese King. I'm a registered nurse here at the University of Alabama at Birmingham. I've been doing this for years, and it's something that I absolutely love. And I'm completely honored to be here this afternoon and speak with you guys about high-risk pregnancy. First of all, we'll start with, what does BIPOC stand for? You would be so surprised at the number of providers, even in my clinic, that did not recognize this and did not understand exactly what it meant. And that is part of why I'm so passionate about what I do. I want everyone to feel represented, but especially people that look like me in this community. So I wanted to go over that first so we all understand the importance of why we're here. Next slide. Just a little bit about my experience and background. I have been doing this now for about 26 years. My area of specialty is women's health. I've done everything from labor and delivery to infertility to maternal fetal medicine, which has been my last 19 years of service here at UAB. I'm currently employed here at UAB, and I serve as the nursing team lead for our office, where we provide perinatal mental health services and prenatal services to all of our high-risk patients. We are a referral-based practice, which means we get referrals from all over the state of Alabama and the surrounding states for all patients that are high risk. I'm also our family support nurse, which basically means one of my roles is here to support families facing crisis, and I will talk about that a little bit later in my presentation. I'm also a member of the Perinatal Mental Health Alliance for People of Color. And any way that I can advocate for my community, I try to do that in every way that I can. Also, I'm a little bit under the weather today, so I'm gonna try to get through this without coughing. But if I take a drink of water, then that's what that's about, because I'm trying to keep my throat moist. Next slide. Let's start with my why. The BIPOC community is one of the most underrepresented communities in healthcare, and that's not okay. I've done this for a long time, and most patients that come here, or all patients that come here, either have issues with themselves or with their baby, and they're terrified. They're anxious. They don't know what's going to happen. They don't understand the diagnosis. And when you go into a place where no one looks like you, it heightens that anxiety. Also, there's very little to no representation for people of color amongst attending physicians. I've been doing this for about 19 years here in maternal fetal medicine, and I've only had a few attendings that were African American or people of color. Lots of residents, but there's just not a lot of people here that look like us. And when you're putting the life of yourself and your baby into someone else's hands, sometimes it's hard to trust. So it's important for me to form relationships with those patients when they come in, letting them understand that I will be here to advocate for you. I will be here to speak for you when you feel underrepresented. I will be here to make sure that you understand what's going on with you and your baby. I want them to understand that I see you and I'm here for you. So if your doctor doesn't look like you, at least you have a nurse that understands what you're going through, can identify what you're going through, and is here to help you. I hope to build a sense of trust and advocacy for my patients. Sometimes they just don't feel heard, and that's not okay. So I want to be here for them in that instance. Next slide. So what is high-risk pregnancy? Let's start there. There's lots of people that think that they are high risk, and there are so many diagnoses that we can put into this category. But the best definition is a pregnancy in which a mother or her fetus faces a higher than normal chance of experiencing problems during and after delivery. These risks may be due to factors with the pregnancy itself or may stem from pre-existing maternal conditions. And there are so many that we can add to the list. In my practice, we see patients anywhere from a simple diagnosis as obesity, which places you at higher risk, all the way up to heart failure patients. So there's a vast majority of things that are considered high risk and everything in between. So I have patients who are diabetic, I have patients who have lupus, I have patients who have chronic hypertension. I have patients who are currently receiving cancer treatment for various reasons and figured out that they were pregnant. So what do we do in that instance? I have transplant patients who have, new kidneys, new hearts, all of these things. And a pregnancy in the middle of that comes with certain complications. And those are certain things that we have to take care of. On the fetal side, there are so many reasons that a mom may be here because of her baby. Any abnormal ultrasound that's discovered is sent to us. And we will rescan that patient here in our office. And depending on the diagnosis, we may recommend that that patient deliver here with us at UAB. We have a phenomenal nursery. And our neonatologists are top notch. I work with them very, very closely. And they are some of the best in the country. So those are some reasons that a pregnancy would be high risk. Next slide. So we've discovered that we may be high risk. So what now? Here comes your anxiety. The first thing you would want to do is to understand what's going on with you, what makes you high risk, and what is going to be your plan of care. Next slide. The first thing that you would want to do would be to talk with your physician about your particular medical complication. Why are we high risk? What makes us high risk? How is that going to change our pregnancy? How is that going to change our management? What things do we need to do differently than you would in a low risk pregnancy? So your first step is talking with your physician. Every woman should have a couple of different physicians. You should have a primary care physician that takes care of your needs each week. You should have an OBGYN also who cares for your OBGYN needs. And you should have both of those doctors that you see on a regular basis. Your OBGYN will be able to direct you to a specialist that you can talk to prior to pregnancy. And they will be able to give you a plan of care based off of your medical condition. You want to understand your diagnosis, the risk and benefits of pregnancy. You want to begin taking a prenatal vitamin. You also want to eat a healthy, balanced diet and exercise a couple of times a week. Your self-care is very important for your mental health and your physical health. Next screen. So what do we do with a positive pregnancy test? The first thing you want to do is contact your physician and schedule your initial appointment. You want to review medications. You want to educate yourself on all available aneuploidy screening. Continue a healthy diet. Exercise 3 to 4 times a week. Also, we want to make sure that you review your medications with your physicians. There are some medications that are required to be taken off when you become pregnant, and some things we want to stop prior to pregnancy. So we want to pay attention to those things. Next slide. So what do we do? What do we do now that we're pregnant? For high-risk prenatal care, You are seen every 3 to 4 weeks during the first trimester, about every 2 to 3 weeks during the second trimester, and weekly after 34 weeks. The frequency of your visits may change according to your diagnosis. There are some reasons you would need to contact your physician if you're having complications. Anytime you're pregnant and having painful contractions, more than 5 in an hour, bleeding like a period, leakage of fluid, or decreased fetal movement in the late second and third trimester, those are always reasons to contact your physician. Another complication that we see a lot is preeclampsia. And in the BIPOC community, we are predisposed to preeclampsia. Those symptoms are a headache unrelieved by Tylenol, upper abdominal pain, visual changes, and increases in your blood pressure. We also recommend that everyone take an 81 milligram aspirin to decrease the chances of preeclampsia. You want to educate yourself on breastfeeding and the benefits of breastfeeding, because breast milk is always going to be best for our baby. Next slide. So what are some of the benefits of breastfeeding? It's easily digested. It costs less than formula. It contains all the nutrients that your baby needs. Mothers can feed their babies on the go without having to worry about mixing formula. And breast milk protects against infection. I would recommend that you meet with a lactation consultant while you're pregnant, take a breastfeeding class, and also get your breast pump. What's the goal? The goal is a healthy baby and a healthy mom. And the only way that we can have a healthy baby is for mom to take care of her physical and mental health. Next slide. So what happens when we don't get to deliver good news? My passion and a program that I've developed here at UAB is what's called our Compassionate Care Program. We don't always give the good news. We have some circumstances where we don't give good results, and we know that we're not going to have a good outcome. So what do? I had a patient tell me after her miscarriage that she felt like she was kind of dropped off after her care, and there was no contact with the nursing staff or physicians that she had formed these valuable relationships with. So that prompted me to educate myself on how I could take care of these patients better. About 6 years ago, I attended a program called Resolve Through Sharing, which is the gold standard in bereavement care for prenatal patients. And I did training and developed a program to care for patients. Next slide. And my passion and what drives me is to make every birth beautiful, no matter the circumstances. Next slide. So through that was born our outpatient and perinatal bereavement program and our comfort care clinic. It is a comprehensive program designed to provide ongoing care for the needs of families experiencing perinatal loss. It provides a multidisciplinary care in the setting of life-limiting diagnosis, and it provides compassionate health care to subsequent pregnancies following perinatal loss. At the time of diagnosis, like Ashley said, her baby had omphalocele. We began a comprehensive and multidisciplinary approach to preparing those families for delivery. What is that delivery going to look like? What services do patients need after delivery? What mental health needs does mom need now? And how are we going to follow her after delivery? Next slide. The components of that healthcare team are maternal fetal medicine specialists, neonatologists, our high-risk sonography, our social workers, our nutritionists, our cardiologists, our surgeons, Of course, our MFM nurses and our outpatient and inpatient bereavement coordinators. Next slide. Anytime we have a patient with life-limiting diagnoses, we want to prepare those moms and families for what's going to happen. What does that look like? What'll happen when we get to the hospital? What'll happen following delivery? Sometimes we diagnose these losses in clinic. So how do we care for those patients? If it's the first and second trimester loss, we're going to mail out a sympathy card. I will follow those patients about 7 to 10 days after delivery. At their postpartum visit, they will have depression screening, and a nurse will call them about every 4 to 8 weeks after delivery. I also follow these patients for about a year after delivery. I make sure that they have all of the mental health services they need. I generally will touch bases with them around Mother's Day, around the anniversary of baby's birth. I also like to put together memory keepsakes depending on the patient's gestational age. If it's a third trimester or neonatal demise, they also get a sympathy card, their depression screenings. Of course, the postpartum visit, we will always follow up with them, and they will get those nurse visits every couple of weeks. We also prepare them a memory box and memento photos, if we're able to do so, of their baby. We want, even in the face of a tragic delivery, to be able to give moms and dads something beautiful about that delivery that helps them memorialize their baby and have some sort of positive experience. Here at UAB, I work very closely with the Amelia Center. They are a center here at UAB that works between us and Children's Hospital, and their sole purpose is to counsel patients who are grieving the loss of a child. They have programs for mom, for dad. They have group support and also individual support. And the amazing thing about that is that it's completely free to the patients. So I utilize their care often. Next slide. So our comfort care protocol also was developed from a family who had care with us that lost their little one, and they wanted to be able to give back to the community in some way. So they also help us with caring for these families. The comfort care protocol is initiated anytime we have life-limiting diagnoses. This will also include neonatology and palliative care visits, delivery planning, coordination of final arrangements depending on gestational age, referral to the Amelia Center, and the initiation of postpartum care and extensive bereavement services. I work very closely with Dr. Brian Sims. He is an African-American neonatologist here at the hospital. He will meet with patients prior to delivery so that we can form a relationship before we're standing over a baby and trying to make the most important decisions of our lives. So we have found that by having that relationship on the front end, it decreases the anxiety afterwards when you have that baby there and you're trying to make those decisions. Next slide. Most of my patient education centers around father's grief, caring for yourself after loss, stillbirth, how are we going to plan our goodbyes, and also grief of grandparents. Next slide. A big part of our care also is subsequent pregnancy after loss. And most people know that as rainbow baby. Mothers have so much anxiety the next pregnancy after they've had a loss that they need very specialized care. And so we try our best to provide that. I've had moms call me numerous times. They just want to hear the heartbeat because this is the time that it happened last pregnancy. Or If I can just get past the last point of miscarriage, I will feel better, and I will hold their hand. I will walk through that. I have brought patients in on days when they didn't even have a doctor's appointment to let them listen to heart tones. I have done all of these things depending on what's going on with that patient. If that will help ease their anxiety for that moment, then that's what we'll do. I always tell my patients, I would rather you call me and let's talk about it than to sit at home and worry. So that's the care I try to provide. Next slide. So what to expect when providing care for a rainbow pregnancy? Very high anxiety, more frequent visits, more testing dependent on prior complications, increased anxiety, increase in perinatal mood disorders. They were going to have more depression, more anxiety, more panic disorder, and more OCD. And they also struggle with extreme guilt. They feel guilty for being excited about this baby when they're still grieving the loss of the last. Next slide. So in conclusion, I always tell patients, be proactive in your healthcare. Educate yourself, understand your risks prior to pregnancy, seek an experienced professional, always follow the recommendations of your physicians, and always seek support because you do not have to do it alone. And here's my contact information if anyone would like any information on what we do here at UAB. If you would like for me to speak with your office on how you can develop a similar program, I would be happy to do that. And again, I apologize for being under the weather today. I kind of struggled to get through this because I'm not feeling well, but I definitely wanted to keep my commitment and be here.